Okay, glad I caught that early. I was talking and I didn't have a microphone on and I didn't have the camera on. So let's start over. So Dr. Sporbert here for 114. This is your voiceover concepts on the mental health component for Nursing 114, which comes during modules 5, 6, and 7. There are several concepts. The first concept is on cognition, and we're going to cover Alzheimer's disease, dementia, delirium, and schizophrenia. Schizophrenia is one of the hardest psychiatric diseases to successfully treat. It's one of the highest readmissions, high suicide rate, and high inability to function successfully in the community. Then we have personality disorders, which falls under the concept of self, as well as self and self-image with anorexia nervosa and bulimia. Stress and coping, which covers anxiety. Particularly, we focus on PTSD and obsessive compulsive disorder as a treatment of anxiety, which is not a reliable and or effective coping mechanisms. You do cover the component of generalized anxiety in 112. So whether you hit that before you get to me for it, it'll be a review and or I will start talking about general anxiety disorder, and you'll have it going into the 112 piece of it for that class. And then we have depression and bipolar disorder, 1 and 2, which falls under mood and affect. So a lot of content in a very short period of time, but I'm not going to go through each individual concept because that would take a long time to discuss. So I'm going to do a broader overview of mental health as a concept itself holistically. So looking at specifically stigmatism, the barriers that exist for accessing care, and then talking about cultural biases. Therapeutic communication, of course, plays a significant role in sense of safety. And we have our own self-awareness and reflection and our own potential personal biases. I can't speak for other folks, but I do know that teaching 114 as long as I have, and having my own mental health issues of severe anxiety, which is not as severe as it used to be, has provided me an awareness of being more empathetic toward people who have mental health issues or concerns or disorders. Anxiety and depression lives pretty much beneath the surface of all populations in the United States, and I consider it sort of insidious. It's not like really in your face. People manage or don't manage, but it's part of everyday life, whether it's situational anxiety, depression, or chronic, genetic, etc. So whereas your schizophrenics, your dementia patients, your eating disorder patients, your personality disorder patients, these folks have definitive diagnoses that some of the time and or all the time, depending on the diagnosis itself, are very predominant in how folks do or do not manage in society, whether it's relationships, jobs, finances, keeping roofs over the heads, etc. So something from a minor inconvenience, if you will, to something definitely on a larger scale and more of a continuum, a much more of a problem. There may be some of you who want to pursue mental health. We have mental health rotations in this class. As you know from clinical orientation, we have mental health rotations for Dorothea Dix, which is pediatrics. We have Psych ED, which is for emergent psychiatric care. And we have behavioral health, which is adult care. The Dorothea Dix and the adult care are both in the buildings at the end of Melrose Road on the left-hand side, and Psych ED is actually within the hospital itself. There is an inpatient psych unit over near 4 South or the PICU, 4 North and the PICU. We have not garnered access to that yet for students. But post-COVID, mental health has really become much more of a focus, if that's the word we want to use, where we're paying, one hopes, a little bit more attention. So basically, the management of mental health is medication and therapy and support systems. And that's always precarious itself with support systems. So when we look at stigmatism, some of the key points that impact patients' ability to seek care or wanting to seek care is the sense of shame and the responsibility that we take upon ourselves, that we feel that we're being flawed, whether there's a genetic predisposition or not, whether we're already predisposed, especially women, transgender, veterans, homeless, geriatrics, children, teenagers. It might as well just be the entire population. There's still a stigmatism, and I'm not sure it'll ever go away, where people just don't want to seek out care, and they will hide their mental health because of embarrassment, or if they have sought some type of care and have been met with poor outcomes or poor treatment, they're less likely to return to seek assistance again because of the perception of the first initial encounter. As I've said, perception is everything. And that could be any hospitalization where someone has a bad experience or a bad experience, is less likely to seek out health care later on down the road. Some folks will talk about it openly, some folks won't. It really depends on cross-cultural congruency, cultural continuum. Some cultures think it's a taboo and will not talk about it. And treatment does not exist for certain cultures. So we have to be mindful of that. We have to be conscientious of that. So if you're not going to specifically specialize in psychiatric nursing, you will be taking care of patients with underlying psychiatric diseases and or disorders. Especially if you're in the geriatric field, you're going to run into patients that have Alzheimer's, have dementia. Schizophrenia is at any age group. Delirium is an acute episode of confusion. We talk about that extensively in class. So we really have to get at what is the stigmatism that's specifically affecting this particular patient and or family members and support systems, and how do we, within ourselves, which is our next couple of slides, how do we, even at the bedside on a med-surg floor, pediatric ICU, labor and delivery, psychiatric health is in all of us to some degree at some particular level. And so we talk about it with the 9 hours that we have. Barriers to care will include the stigmatism, will include shame, and will include embarrassment. So as I said in the first two PowerPoint voiceovers, most of the United States of America is rural. And so it's hard enough just accessing medical care in general. We lack physicians in rural areas because they can make better money in the cities. So therefore we've populated schools with nurse practitioner programs to offset the lack of providers out there. But these folks don't work in the clinics and in the communities outside of cities because they don't make the kind of money they can make. So you already have a limited population of providers. In addition to, we still as a country have less dedicated mental health services in this country. One of the things that we talked about, or we will talk about, is that Dorothea Dixon Behavioral Care Centers, the independent structures at the end of Melrose Road associated with Keyfair Valley, have only been open for a couple of years. I'm not good, but my memory is still intact, but I think they opened before COVID, so 3-4 years. But before that, if you're from the Fayetteville area and you've been here for a while, had a center called Roxy, which was for addiction withdrawal issues and psychiatric service. It closed. It closed due to lack of funding. So from a federal level to a state level to a local level. So when you take away federal funding or you limit Medicaid and Medicare insurance services and you cap people out, they don't have the finances or the insurances to cover care, therapy, medications. So you have that as a geographical and financial concern. And some folks just don't have the ability to recognize that they need care. They may have schizophrenia, and that again is one of the reasons that this disorder is so very difficult to treat, because people or culture don't recognize that it's a disorder and that it requires medications to stabilize the delusions and the hallucinations. Same thing for bipolar. Bipolar is typically has been more of a female mental health illness, but it's driven either by frequent episodes of mania or frequent episodes of depression. But it's an unequal mood. They're not stabilized, or either or. And so it does require medication to stabilize the moods. So some folks may just not recognize that they need care. People can be depressed and not know it. Apathy is just lack of interest, lack of hope, lack of motivation. So that's why when folks are depressed, they may have a thought process of suicide, but they have no motivation to go through with the plan. So when we put them on certain antidepressants such as SSRIs, we really have to watch them for the first 2 to 3 weeks of medication, because that's when they begin to feel hopeful. That's when they become more motivated, and that's when they become to care. That's when they're at the highest risk of killing themselves. And we have a lot of medical diagnoses that will mimic psychiatric symptoms. Anxiety can cause chest pain. And I share my story with students, and I won't do it here, but I will when we are face-to-face in class. Chest pain can be a result of anxiety and not a true cardiac event. Folks who are insomniacs, that's a medical diagnosis, can have psychiatric concerns of either depression or anxiety. So sometimes they're mislabeled, mistreated, lack of knowledge. I can't speak for how much mental health providers get during their training. I can tell you as a nurse practitioner, I had a mental health course itself that was 16 weeks, but I love the program that I work for, but we teach 9 hours of mental health in this curriculum, and you get anxiety in 112. You get some partner violence and alcoholism in 211 and 212, but that's it. We don't offer, a specific mental health course. So if you're truly interested in making this a specialty, in addition to really understanding your patients at the bedside and underlying disorders, for lack of a better word, then we need to be lifelong learners in this field. Excuse me. So biases in communication. I'm not a great therapeutic communication person. I mean, one of the biggest things I chronically do is if you go to the OR with a patient and you were to say to them, don't worry, everything's going to be all right. Well, that's probably the worst thing we can do, because we don't know, but it makes me feel better. So I'm just speaking for myself. So some of the challenges are that we don't really understand our patients' cultural, social backgrounds. So sometimes we really don't know how to talk to them. And therapeutic communication is great when you're in the milieu or you're in the arena and you're practicing psychiatric care. You're going to learn dialogues and conversations and ways. You're going to be trained in how to talk to your patients in a way that is therapeutic. But at the bedside, we don't really have that specific type training. So we have to be very much more cognizant of that, especially if your patients don't speak or English isn't their first language. And that's going to affect your assessments, and that's going to affect the time spent of getting a translator machine into the patient's room, which is a policy of Cape Fear Valley. We can't use family members. We have to actually, when we use a translator through the system, at the green TV screens on wheels, we have to document in Epic when we use a translator what the session number was, the date, and the time, because there have been too many, or there have been cases where nurses, for whatever reason, aren't using the translators and are using the family members, and we know that that's not accurate. So again, that's why we have best practice, and that's why the federal law mandates trained professional interpreters, and that's what Cape Fear Valley is stressing that we use per their policy. And as I've already said, we don't use family, friends, or interpreters as interpreters, because it's when you get emotional about something, there's the relationship of the family member to the patient is going to affect what you are getting from the interpreter. All right, that relationship it's not objective and it's not professional. It's laden with emotional stuff. So I always call it hallway thoughts. And for our course in 114, I'm going to be your sim teacher, sim instructor. I'm only on the units for Miss Veronica's students on Friday. But one of the things I learned in NP school, and again as a RN, is that when I get my patient assignment, I get report, and I kind of like put myself into check. I struggle bus when nurses say, I had a rough night, that patient, that family member, um, constantly ringing the call bell. It will set anybody up to think, oh boy, this is going to be a tough day because of that patient. So be mindful when you're given report to be objective and stick to the facts. Let that nurse figure out that relationship with that patient when they get into the patient's room. But sit outside the hallway and ask yourself, besides how you're going to set up your clinical practice, and let's say they are there for X, Y, and Z, but have a significant underlying disorder of depression, then how is that going to affect the care you're going to give? Ask yourself, do your own reality check. How are you going to incorporate empathy? How are you going to assess depression? What assessment tools are you going to use? Are you comfortable in asking a patient, do they have a plan of committing suicide? And if so, what does that plan mean? You're not increasing the risk for suicide, but you're being objective, because we need to know if patients are in severe major depressive disorder, they're at a high risk for suicide. And most likely they're going to be on suicide precautions and have the protocols put in place. But my point being is, do you know as a human being and as a person what biases you have? And if so, what is it towards, and how do you plan on fixing it? If you don't have any plan to fix it, then that's an area that you should not be working in, because your biases will affect the care you get, whether you know it or not. So understand what's going on with your patient. Do your evaluation of yourself, because that's going to affect the relationship. And you learn this in your 111 training, and if you work in the medical field, you already know this. You want to establish a trusting relationship with your patient. I get time constraints. I get 6 patients, been there, done that, but we can make an impact in 5 minutes. So I really believe that we make excuses sometimes for what we can't do, and versus what we can say, this is what I have the time to do, and this is what I'm going to do. So strategies, get your clinical instructors to help you with the dialogue. I don't recommend taking your technology with you to your clinicals, but I do know students take their tablets. I had a student last semester on 3VPN on Friday who had a patient who had major depressive disorder, and he came to me and he said, I just am really struggling with how to have a conversation with him, how to get him to come out of his shell, how to get him to talk to me. And so we talked about some techniques that I had learned, but he went to another student and she told him to go pull up Elsevier and go to SharePath AI and type in how to have a conversation with a patient who's depressed. And the amount of therapeutic communication questions this student got and was able to print off on the unit made a world of difference to that patient. And that student had a phenomenal day just because of using resources. So I strongly encourage you, even if you don't bring your laptops or your tablets or electronic devices, ask your clinical instructor if you can jump on a computer and go to the internet and go to Elsevier and go through the SharePath AI, because you are working with a student and you're using your Elsevier resources. So you are conducting clinical, you're not doing academic work. Again, self-reflection, be aware of your own beliefs and influences and how you interact with others. Well, this is my biases. You can specifically go into psych nursing, obviously. You will be appropriately trained. There are many modalities, and by that I mean many different ways that psychiatric treatment is provided. So what I've heard, and you can have this discussion with Ms. PK, who will be overseeing the mental health rotations for us for 114, is what are the modalities at Dorothea Dick, Psych ED, and behavioral health? Is it group and individual therapy? Is it medication specifically? What kind of modalities are being used to try to return the patient to baseline and or improve current state? And how to be proactive to reduce exacerbations and hospitalizations moving forward. So I encourage you to have that conversation. I have heard from students that the modality is medication administration. And we talk heavily about meds in those 3 Tuesdays later in the semester. As I said earlier in previous PowerPoint voiceovers, we're all getting older, but technology and medications is keeping us alive longer. So you can have folks that have been schizophrenic in middle years, middle age, teenagers, etc. But now they're in their 60s and 70s, and that is considered geriatric. So as they get older, they have their psychiatric diseases, or they have dementia, or they have not delirium, excuse me, or they're schizophrenic, and it grows old with them, if you will. So we're always lifelong learners as nurses. But I think it's incredibly valuable to really step back and make sure we understand opportunities available if that's something that you're interested in, and then try to understand that you will be on a day-to-day basis, whether you specialize in it or not, you will be working with patients who have underlying psychiatric issues or disorders. Years ago, when I first started teaching 114, I was not a mental health RN. I didn't practice that in my private practice. I wasn't a mental health nurse in the home care that I did for 20 years. Mental health scared me because I didn't understand it. And so I obviously had to teach it, and I had to figure out a way to learn it, but I became sympathetic because I didn't recognize what was happening to me internally. Once I reflected back on myself personally, and I share my story in order to help other students or people understand that we as practitioners, if we're scared of it, then that's what we give off as a vibe and a perception to our patients. So I'm not asking you to embrace it. I'm asking you to be empathetic towards it and spend some time consciously in the moment thinking about how you are going to use this component of your education in patient care, again, whether it's specialized or not. So there's some scenarios that I wanted to throw out there because I think, again, students consistently will say, I don't know how to talk to them. And you're right. What kind of experience have you had unless you work in psych? So the scenario 1 is on stigma, which goes back to the first PowerPoint slide. So this is a 45-year-old female who reports to the ED complaining of chest pain. So because it's Maslow, the heart, we're always going to do the cardiac workup first, and it's negative for a heart attack. So when we ask her about, stress, what caused, why she whispers, I've been feeling very anxious lately, but I don't want that in my chart. I don't want anybody to know that, quote unquote, I'm anxious. So what people going to think about that? And that's relevant. So how do you talk about it? I think the best thing to do is to normalize it. Remove the stigmatism. Everybody has some level of anxiety. The problem is that your anxiety is now affecting you physically and physiologically, and you don't want to have chest pain. And so maybe some of the things are that we also can't share information with other people because that's a HIPAA violation. We also talk about we can treat anxiety like we treat high blood pressure. Medication can work to reduce anxiety, to help you sleep better, eat better, feel better about yourself. And then maybe really asking her, why does this concern you? What's going on that you don't want to discuss it? So everything I just said is completely objective. I've normalized it. I've been open-ended, which is a primary thought for therapeutic communication. I've tried to assess the stigma impact. And quite frankly, I asked AI and SurePath, there you go, to give me teaching points back to you all as to how to address the scenarios that I'm presenting, because I don't practice in psychiatric medicine. So it's like a skill. Therapeutic communication is a skill. You either use it all the time or you lose it. So for the cultural bias, we have a 68-year-old Chinese immigrant, Mr. Chen, brought by his daughter confusion, and she says that she's translating for him that he's seeing ghosts. So one of the discussion questions was the risk of using the family as interpreter, and how might the cultural beliefs about mental illness affect your assessment? Well, we already know federal law mandates that we use a professional, objective, trained interpreter, because we know that information can be misinformed, filter information, violate privacy, especially if the daughter, what if we don't have a HIPAA form and the daughter, or we do and we're not supposed to use the daughter? So that gets in some legal muckiness. Seeing ghosts in Chinese, that's some cultural stuff, but when you're seeing ghosts, it's also visual hallucination. But that's a reality that he sees. Obviously, the daughter and I don't see the ghost, but he does, so that's his reality. So we have to be careful and respect that. We can't turn around and say, you don't see ghosts, but he does. So that's a non-therapeutic response. But I just said the Chinese immigrant is seeing ghosts, and maybe that's a cultural connection. That's a cultural bias that I just threw out there at you, because just because he's Chinese and seeing ghosts doesn't mean this might mean I'm stereotyping. So basically, this is a question that we're needing to understand our own cultural biases, or connecting, whether we know it or not, that Chinese and seeing ghosts may be related, and therefore it's a bias. And that's not the point of the question. The point is, let's get at what's going on with this patient. He's 68 years old and he's a male and he has confusion. So medically, at a 68-year-old, I want to know, was this an abrupt confusion? Does he have underlying dementia? That's how I get past the biases. I dive into a very logical head to toe assessment based on age, based on being a male, based on the word confusion. And I'm going to hopefully be able to teach you all how to get there, or take this piece of it with you when you go into second year. And I think the last one is assessing barriers. Mr. James is a veteran. He has suspected PTSD, and he says, quote, I should be able to tough this out. Asking for help feels weak. So the discussion question is the stigma. How does it intersect with military culture? What barriers might prevent James from accessing VA services? Because he is a veteran, so he automatically has access to services. We live in a military town. Even if we didn't live in a military town, we have millions of veterans in this country. But the veterans do fall under a vulnerable population because of limited care, access to care, increased homelessness, increased risk for PTSD, increased risk for family dysfunction, personal dysfunction, etc. So they fall into that vulnerable category. So because of the quote and what we know about the military, maybe he has some of that inability to recognize that he has post-traumatic stress disorder, but he doesn't want to ask for help because that, as a veteran, it may make others think of him as being weak. So he has his own stigmatism based on his framework of the culture of being in the service. So maybe we can reframe it and say, but if you reach out and ask for assistance, that is being strong. That is providing strength to you to get care. PTSD can cause depression, anxiety, suicidal thoughts. And so be honest with James. Be honest and say that post-traumatic stress disorder, whether it's suspected or an actual diagnosis, will increase risk for anxiety and depression, which in turn can increase risk of thoughts for suicide. So let's be strong, and let's take it upon ourselves to act proactively and seek for assistance. Practical barriers, the VA services, I mean, and this is AI saying this, I don't know this for a fact, but I mean, and I on the periphery have heard, living in a military town, and I'm not military and I have no family members that are, is getting into the VA in a timely fashion for all. Do people make an appointment and can get in the same day? Or are we waiting months on end to get in for appointments? How many doctors are we seeing? Is the barrier to care as apparent as civilian access to care, if you will? And we're advocates for our patients. So this is part of our responsibility, is to know what's available out there. So it's helpful to seek out social working. Connect your folks to services, students that are veterans. There's we have so many resources on this campus, and I still say after 8 years here, it shocks me how many resources we have that students don't even know about. So as an advocate for you, not only as your educator and as your colleague in a few years, but as a person, that's part of our responsibility. So that's what I got. I'll get this posted and we will chat soon. Bye.